I'm Dr. William, 15 years in internal medicine, and I need you to hear something plainly without softening it. Some of the most common medications taken by people over 65 in America are quietly destroying the exact part of the brain responsible for memory, focus, and independence. Not rare drugs, not obscure ones. Drugs sitting in almost every medicine cabinet in this country right now, including, statistically, yours. I want to tell you about a man I'll call Harold before we go any further, because his story is the reason I made this video. Harold was 78, a retired postal worker, sharp as a tack his whole life, the kind of man who did the crossword in ink. Over about 18 months, his family watched him slip. He'd repeat questions he'd asked minutes earlier. He got lost driving a route he'd taken for 30 years. His daughter assumed it was the beginning of Alzheimer's, and honestly, so did his primary doctor at first. Nobody looked at the 3 ordinary bottles sitting on his kitchen counter. When we finally did and made careful changes with his doctor's full involvement, Harold got measurably sharper within 4 months. Not perfect, not reversed entirely, but sharper, present, more himself than his family had seen him in over a year. That is exactly what today's video is about. Today, I'm counting down 9 of them, from the ones that slip under the radar to the one I believe is the most dangerous of all. Stay with me to the end, because the last one on this list isn't even filed as a memory drug. It's rarely questioned, rarely reviewed, and it may be the single biggest hidden driver of preventable cognitive decline in older adults today. Before we start, I need you to do something. Drop your age in the comments and tell me honestly how many prescriptions you take every single day. I read every comment, and what you tell me shapes exactly what I cover next, because this audience is who this channel exists for. Let me give you the one concept that ties this entire list together, because once you understand it, everything else will make sense. Your brain runs on a messenger chemical called acetylcholine. It is the signal your neurons use to write a new memory and to stay sharp through the day. Think of it as the ink your brain uses to write in its own notebook. No ink, no entry, no matter how important the moment felt while you were living it. As you age, your brain makes less of it naturally, and it depends more heavily on every bit that remains. A disturbing number of common medications block that exact signal. Some directly, some as a quiet side effect nobody flags, some for a genuinely good reason that still comes with a cost nobody explained at the counter. That mechanism has a name, anticholinergic activity, and it runs underneath most of what I'm about to show you. Though a couple of these drugs work through a completely different pathway, and I'll be clear about that as we go. This is not an attack on modern medicine. Every drug on this list treats something real, often something serious. My job today is to make sure you're taking it with your eyes fully open so that if memory starts slipping, you and your doctor are looking in every direction for the cause instead of quietly assuming it's simply age. Let's begin. Number 9. And don't let the low position fool you, because this one is sitting in nearly every home in America. Number 9 is diphenhydramine, the active ingredient in Benadryl and in almost every nighttime cold and sleep medicine on the shelf. It requires no prescription, it costs a few dollars, and that alone convinces people it must be harmless. It is not. Inside an aging brain, it blocks acetylcholine directly, and the structure that absorbs the damage is your hippocampus, the small seahorse-shaped region where new memories are formed before they're filed away for good. Picture a filing clerk trying to sort the day's mail with both hands tied. The mail piles up unsorted, and by the end of the day, most of it simply gets thrown out. One tracking study found regular anticholinergic antihistamine users over 65 carried as much as a 50% higher risk of cognitive decline within a decade compared with non-users. I think of a man I'll call Frank, 76, who took a nightly allergy pill for years and never once connected his fading memory to the pink tablet on his nightstand. When we switched him to a non-anticholinergic option, his daughter told me within weeks he seemed sharper than he'd been in years. Here's what to do. Read the label on anything marked PM, nighttime, or allergy relief, because it is very often diphenhydramine hiding under a different brand name, dressed up in packaging that doesn't sound anything alike. Ask your doctor about a newer antihistamine that does not cross into the brain the same way. Do not simply stop it tonight without a plan. Talk to your doctor first, and if you've genuinely struggled with insomnia rather than an occasional allergy flare, that itself deserves a real conversation instead of a nightly workaround. Number 8 is the acid reflux pill, the proton pump inhibitor family. The omeprazoles and esomeprazoles taken daily by millions for heartburn. People stay on these for years because the moment they stop, the burning returns with a vengeance. Here is what almost never gets explained at the pharmacy counter. Your stomach needs acid to absorb vitamin B12 from food, and B12 protects the insulation around every nerve in your body, including the ones in your brain. Suppress that acid long enough, and B12 quietly drops, taking clear thinking with it. One large study following adults over 75 found regular long-term PPI users faced a 44% higher risk of a dementia diagnosis compared with non-users. I think of a woman I'll call Helen, 79, on the same reflux prescription for over a decade, who had started forgetting the names of neighbors she'd known for 30 years, forgetting them mid-conversation in a way that embarrassed her deeply. Her B12 level came back at the very bottom of normal, low enough to matter, high enough that no one had ever checked. A few months of supplementation and a lower dose, and her family said she sounded like herself again on the phone within weeks. Do not stop this medication cold, since rebound acid can be genuinely miserable and even damaging. Ask your doctor if you still need the same dose. Ask for a B12 check if you've been on it for years, and know that many people can safely step down to an as-needed schedule without their symptoms roaring back. Number 7 is oxybutynin, prescribed for overactive bladder, a problem most people would rather not discuss out loud. It blocks acetylcholine directly, and it crosses into brain tissue with alarming ease, doing mechanically almost the exact same thing as the allergy pill at number 9, just with a stronger daily dose. Adults over 65 using strong anticholinergic bladder drugs like this one for more than a year showed close to a 50% higher risk of a dementia diagnosis in one tracked group, nearly 1 in 2. I remember a patient named Carol, 73, who came to me convinced she was developing early dementia because she kept losing her train of thought mid-sentence. We switched her to a newer bladder medication that doesn't touch acetylcholine at all, and within 6 weeks, the mental fog had cleared completely. Same bladder control, none of the cost. If this is you, that conversation with your doctor could change everything, and it rarely requires giving up control of your bladder to protect your mind. Number 6 might surprise you because it's one of the most prescribed medications on the planet, statins. I want to be careful here because this is not an argument against them. They save lives by protecting your heart, and for many of you, they belong in your daily routine without question. But your brain is nearly 60% fat, and it depends on cholesterol to insulate every nerve fiber inside it. The same way rubber insulation protects a wire from short-circuiting, push cholesterol down hard enough, especially with the statins that cross more easily into brain tissue. And some patients describe a real fog, a blank space where a familiar name used to sit, a hesitation before a word that used to come instantly. One study following adults over 70 on high-potency statins for more than 3 years found roughly a 26% higher rate of reported mild cognitive impairment, though other large studies found no such link at all, and some even found statins protective. This one sits in the middle of the list because the picture is genuinely unsettled. If you notice fog on a statin, that's a conversation about dose or choice, never a decision to stop on your own. Number 5 is Zolpidem, sold as Ambien, one of the most prescribed sleep aids in the country. It doesn't touch acetylcholine at all. It works through a different calming pathway called GABA, but that pathway governs how your brain files memories overnight during deep sleep. Sedate that process nightly for years, and the filing simply stops happening. Older adults using Zolpidem regularly for more than a year showed measurably higher rates of next-day memory gaps alongside a fall risk that climbed by roughly a third. I think of a patient named Ruth, 81, who couldn't recall entire conversations from the night before that her family swore she'd fully taken part in, laughing, asking questions, engaged the whole time. The drug wasn't erasing memories after the fact. It was preventing them from ever being stored in the first place, like writing in a notebook while the ink runs dry mid-sentence. The fix is a slow, supervised taper paired with real sleep strategies like consistent bedtimes and reduced evening screen time, never a sudden stop, which can bring rebound insomnia even worse than what you started with. Number 4 is amitriptyline, an older antidepressant still widely used for nerve pain, migraines, and sleep. Its versatility is exactly why it stayed in circulation for decades. But underneath that versatility sits one of the strongest anticholinergic drugs still in common use. Adults 65 and older with the heaviest cumulative exposure to strong anticholinergic drugs like this one showed a 54% greater risk of developing dementia over a 10-year period in one well-known study. It's often started for one temporary reason and simply never revisited for years. Ask about duloxetine or gabapentin for nerve pain or low-dose doxepin for sleep, both far gentler on this exact pathway, but only through your doctor, never on your own. Number 3 is the opioid pain medication, the tramadols and oxycodones handed out after surgery or for chronic pain that never fully resolved. These don't work through acetylcholine. They act on entirely different receptors, but chronic use carries its own well-documented cognitive cost. In one tracked group of adults over 70 on daily opioids for 6 months or more, nearly 1 in 3 showed measurable declines in attention and working memory. I think of a patient named Gerald, 75, still on a temporary post-surgery opioid 3 years later, describing entire afternoons he genuinely couldn't account for. Not blackouts, exactly, more like hours that simply vanished from the record. A gradual taper alongside a real pain plan built with physical therapy and a non-opioid regimen, and those missing afternoons stopped within 2 months. If you've been on one of these for months or years past the original injury, that's worth revisiting, not because your pain isn't real, but because the treatment deserves a second look once the body has had time to heal. Quick pause, because we're deep into this list now, and I wanted to reach the people who need it. If any of these are hitting close to home, take 1 second and subscribe. And if you know someone taking 3 or more prescriptions every day, send them this video right now, not next week. This is exactly what a rushed appointment never has time to cover. Number 2 is benzodiazepines, the lorazepams, diazepams, and alprazolam prescribed for anxiety and sleeplessness. 2 of the most common complaints in this age group, and 2 of the hardest for a rushed appointment to address properly. At first, they feel like a rescue. The racing thoughts finally slow. Sleep finally comes after months of struggling. Over months and years, that same calming effect settles over the entire brain like a fog that never fully lifts, dulling not just anxiety, but alertness, memory, and mental flexibility right along with it. One large study following seniors for 6 years found those using benzodiazepines longer than 3 months carried a 51% higher risk of developing Alzheimer's disease, with the longer acting versions carrying more risk because they linger in the body longest. Here is the part that makes this genuinely dangerous. Stopping one of these suddenly after months of use can be life-threatening. If you've been on one for more than a few weeks, do not stop on your own, ever. Work with your doctor on a slow taper measured in months and ask about non-sedating alternatives like buspirone. And now, the one I believe is the most dangerous of all. Before I tell you what it is, one more thing. Type the number 1 in the comments if you've made it this far, because I want to know how many of you are still with me for the biggest one on this list. Number 1 is antipsychotic medication. Drugs like quetiapine and risperidone, originally built for schizophrenia and severe bipolar disorder, now routinely handed to older adults off-label for something as ordinary as trouble sleeping or mild restlessness. Powerful drugs designed for severe illness, given out in ordinary homes for symptoms as simple as agitation. One tracking study following over 25,000 older adults found those given antipsychotics for behavioral symptoms alone, without a psychiatric diagnosis, were 71% more likely to experience worsening cognitive decline within a single year. I think of a woman I'll call Patricia, 84, started on a low-dose antipsychotic simply because she was restless at night and difficult for overnight staff to settle, with no psychiatric diagnosis on file anywhere in her chart. 6 months later, her daughter said she barely recognized her mother, not because of illness, but because of a flatness that hadn't been there before, a kind of quiet absence, even while her mother sat right in front of her. We found untreated pain in her hip that nobody had properly addressed, adjusted her lighting and evening routine to reduce agitation naturally, tapered the medication slowly under close supervision, and weeks later, her daughter told me, in tears, that her mother's sense of humor had come back. If you or someone you love is on one of these, for sleep or restlessness, rather than a diagnosed condition, ask directly, why was this started and is it still necessary right now? And here is the twist that ties all 9 of these together, and it's more dangerous than any single drug on its own. It's called anticholinergic polypharmacy, the slow, invisible stacking of several of these medications at once. Picture a nightly allergy pill for sleep, a bladder medication during the day, and an old prescription for nerve pain in the evening. Alone, each barely registers. Together, the burden compounds fast. One large tracking study following more than 280,000 older adults found those with the highest total anticholinergic burden across multiple medications carried a 120% higher risk of dementia within a decade, more than double, and almost none of them knew they were stacking these drugs at all. Nobody ever sat them down and added it up. Here's the part that should give you real hope. Medication-related cognitive decline is often reversible when it's caught early. Reduce the burden with your doctor's guidance, and many people regain real clarity within weeks to months. Your brain is far more resilient than most people are told, but only once the source of the fog is actually removed. If any of this matches what's sitting in your cabinet, hit subscribe, because I publish a video like this every single week, and share this with anyone you know, taking 3 or more prescriptions today, not next week. Here is your action plan, and it does not require a miracle, only one honest conversation. Sit down with your doctor or pharmacist, bring every prescription bottle, every over-the-counter product, every supplement sitting in your cabinet, and ask directly, what is my total anticholinergic burden, and can any of it be reduced safely? Write your questions down beforehand if you need to, because appointments move fast and it's easy to forget in the moment. That single conversation has changed the trajectory for more of my patients than almost anything else I recommend in this entire practice. I want to close with the truth I tell every patient terrified they're losing themselves. Some slowing down with age is normal, and no medication review erases that entirely. Nor should it, because expecting perfect youthful sharpness at 80 is its own kind of unfair standard. But what looks like the start of decline is very often a bottle on the shelf nobody ever questioned, a prescription started for a good reason years ago and simply carried forward out of habit ever since. The only way to know which one you're facing is to look together with someone qualified to weigh the full picture, not guess from the outside based on what everyone assumes about getting older. Your brain is not required to die in silence. You are allowed to ask questions. You are allowed to demand a real explanation instead of a shrug. And it is never ever too late to ask for one. And everything in this video is for educational purposes only and is not a substitute for personal medical advice, diagnosis, or treatment. Never stop or change a medication without speaking to your doctor first, since abruptly stopping several of the drugs discussed today can be genuinely dangerous. Bring this list to your next appointment. Now, I want to hear from you. Of these 9, which ones are sitting in your cabinet right now, and will you ask for a medication review this week? Tell me in the comments. I read every single one, and your answer might be exactly what pushes the next person to ask the same question. I'm Dr. William. Stay sharp, and I'll see you in the next one.